Hi, I'm Frank Corrigan. I'm an interventional cardiologist with Wellstar Health System in Georgia. And I briefly wanted to talk to you today about a 50-year-old man where our traditional risk factors and risk scores for evaluating chest discomfort did not exactly align with the patient's underlying disease. So here's our case, a 50-year-old man who presented to one of our clinics with exertional chest discomfort. As cardiologists, chest discomfort is the most common complaint that we treat. And for years, we've had risk scores, risk factors, stress tests, all designed to essentially screen for obstructive coronary artery disease. But invariably, there are patients where maybe their symptoms or maybe the risk scores didn't align with the patient's underlying disease burden. So this patient, he has mildly elevated blood pressure. His lipids are not exactly normal. He doesn't have diabetes, but taking all that into account, his prevent 10-year ASCVD risk was 2%. Now, yes, our risk scores are heavily dependent upon age, but in particular, our younger patients who have abnormalities like mildly elevated blood pressure that's untreated, lipids that are untreated, or many other things, we may underestimate their risk. So in keeping with our CT first pathway for the evaluation of chest discomfort, we ordered a coronary CT, and this is what we saw. Coronary CT gives us these beautiful images. On the left, we see that his right coronary artery is normal. On the right, his circumflex is normal. But in the middle, we see his LAD, and in particular, he has critical proximal LAD stenosis due to a non-calcified lesion. And even more important, his calcium score was 0. So in this patient who presented with chest discomfort, he had a 2% ASCVD risk by the prevent score. He also had a 0 calcium score. What if this patient had had less typical symptoms? Would this have been something we discovered? So based on the coronary CT, I'm able to understand what we might expect when we go to the cath lab. And what I think is critically important about coronary CT is that we can prepare our patient for what they might expect when they come to the cath lab. I can prepare my patient and say, hey, look, you have likely single vessel disease that we can likely treat with PCI. Since it is the LAD, it may be that bypass is a better option. Coronary CT allows us to frame the conversation going into the cath lab a whole lot differently than saying, you have an abnormal stress test, now we're going to find out what's happening. Additionally, we can use our PCI planning tools to size the lesion and to predict what angles might be best for our intervention. Here's the patient's coronary angiography. Our invasive angiogram confirmed that there was critical proximal LAD disease. We performed our PCI. Importantly, we knew that the patient had non-calcific plaque, opposed to calcific plaque, such that balloon angioplasty successfully opened the lesion. And here was our result. So we treated his proximal LAD disease with a stent. And after all this, he felt better. But what I think is most important about this case is the fact that he is a 50-year-old man who had a prevent ASCVD 10-year risk of 2%, a calcium score of 0, yet had critical proximal LAD disease. And this is a not too atypical case. I think once a month in our group, we find a case similar to this where our traditional risk scores don't exactly align to our patient's underlying disease burden. So in this patient, he has this high burden of non-calcified plaque in the proximal LAD, which places him at the 87th percentile based on his age and gender. So yes, he has mildly elevated blood pressure. Yes, he has abnormal lipids. and we need to treat that to prevent progression of disease elsewhere. But there is something about this patient that causes him to form atherosclerosis much more aggressively than other people of the same age, gender, and ethnicity. Now, is that having a systemic inflammatory disease? Is it some other risk modifier? I think that seeing this makes us want to really further that investigation to try to understand what about this particular patient enables the severe progression of cardiovascular disease. And if we can do that, hopefully we can prevent future events, not only in the coronaries, but in the neurovasculature or even in the periphery. So using coronary CT, not only are we able to identify disease and treat it with revascularization, we're also better able to understand this patient's risk and hopefully identify those risk factors, treat them aggressively, and prevent future events down the line.